Hello, I'm Richard Westerby from IV Fertility Services, and today we have the amazing Dr. Deirdre Conway from the Utah Fertility Center.
Thanks for
Hello,
having me.
you're welcome. So, you've been practicing now medicine for nearly 15 years. And one of the questions that I have for you is how does somebody coming into this choose their fertility clinic, and how would they choose their doctor?
It's tough because there's so much out there. I think it used to be 10 years ago. I'm embarrassed to say, because I was in practice 10 years ago, that it was more about referrals from physicians, OBGYNs, and direct referrals from doctor to doctor. And the world, as we all know, in fast forward 10 years through COVID, everything's online, right? So people are getting all their information online, social media, friends and family. I would say at least a third of our patients come through friends and family and referrals, just direct from, just talking to their circles of people online, for better, for worse, which makes me sometimes cringe a little bit. But Facebook, Instagram, there's actual support groups for infertility patients, and they talk among themselves when they're struggling with infertility. And I would say at least another third are coming from that. And then really online marketing that we do, but I think it's multiple different venues that come together. Maybe they hear about us through their doctor when they're just struggling with infertility initially, but then they look online and they read about things and they talk to people and they hear about us from multiple different places. And then that's how they make that ultimate decision to see a particular clinic. I think within our specialty, there's definitely different personalities from the physician standpoint as well. So I do feel like there's some patient selection where they may be able to see us talking on our website, or they talk to their friend and they're like, oh, you have to see this particular doctor. So I think in the world of fertility and infertility, more than a lot of other medical specialties, the patients do definitely pick their doctor as much as the clinic. But there's definitely some flexibility there as well. So I think maybe 50-50, it's like the reputation of the actual clinic that they're hearing about. And a lot of the times it is also very specific to the particular physician, because they have had other friends and family that have seen a specific person. And I see that a lot in my patient population that I see here in Utah.
Which is amazing. So you almost have that multiple touch point before they even
Right.
get to you. They've heard your reputation. They've heard you speak online at conferences or webinars or podcasts like this.
Mhm.
And they go, huh, I like the sound of that. And then
Yeah.
they kind of get in touch. I think word of mouth and talking to people who've been through this process is so valuable because everybody's journey is different, but there are key parts to it that remain the same.
Exactly.
If I were coming to you to say, okay, how do you measure success? And why would I choose you over Dr. A, B, or C? What would you then say to them?
That's a great question, because I definitely feel like that could be different depending on, right, the metrics are different. I think at the end of the day, of course, our patients, I mean, 80-90% of them are infertility patients. They've struggled with some type of fertility problem, and they want a baby, right? Like at the end of the day, success, very objectively, is baby in your arms, I think, for the vast majority of our patients, whether they're single individuals, gay couples, heterosexual couples, whatever the case may be, they're coming into this from the standpoint of like they are wanting a baby and they're infertile. And that's at the end of the day, really what success rate is defined as objectively in our, umbrella body of the American Society for Reproductive Medicine, is highest success rates to getting to that goal. But I think there's a lot of other really important parts of the journey that are arguably equally critical, because there are, and actually I got a message from my lab director yesterday with terrible news about one of my patients who had embryos that arrested and they didn't grow out, and they're going to have to, further their journey and do another round of IVF. And the patient said that they had such a great experience in our fertility clinic compared to a prior clinic they were in, that they were still so thankful about the experience that they've had with us thus far, that to them, they were still really happy and assured to know that we're going to do a follow-up and we're going to figure it out and we're going to help them through this. And I think it's really important to keep that in mind from a patient and physician standpoint, because it can be really hard. And I feel always so bad when our patients don't have success. But I think knowing that from the moment they walk in the door to the person that greets them in the front office, to all of the staff that help them throughout the process, which they see way more than they see the physician, to the moment that they hopefully ultimately graduate with the baby, that experience for them is equally important, actually, as the really objective part of the success of getting the baby. And I think you have to keep those two factors in mind.
And I think that's a really valid point, that it's not only the biological success, because that we can control to a certain point, but we don't necessarily have the ability to make everything work the way it should. But what we do have control over 100% is how we react and how we make patients feel.
Right.
And that is so key. And I think when somebody walks out the door smiling, even though the result wasn't what they wanted, because they felt secure, confident, validated, listened, heard, that's amazing.
Yeah. Yeah. And you have to be there for the positives and the low points and like scoop them up and help them. And again, not just the physician, but the whole practice and just everything that we really try and instill in all of our staff to make sure that this experience, especially in those low points for the patients, is as smooth and coddled as possible throughout that journey, which can be really bumpy.
Yeah.
I know, we want it to be as smooth as possible, but it is biology and it just isn't always that way. So really helping them through those tough points is, I think, the most critical part, arguably.
And that's great if we've got the patient already as part of our cohort of patients. But for somebody that's just looking at a video and they've listened to you talking, and then they go on to SART, or the Society of Assisted Reproductive Technology, or to the CDC, the Center for Disease Control, how can they take that data and say, okay, this is a good clinic versus this is not a good?
Well, that's like tricky. SART used to be so much more straightforward. And CDC, I mean, it's similar data. I think you can look at, as long as you're from a patient standpoint, comparing one clinic in one way the same as what you're looking at in another clinic, it should be similar as long as you're matching for age and you're looking at exactly the same statistics from one clinic to the next. I do think it's gotten a lot trickier over the years because IVF is so much more complicated than it used to be. It's not how it was even 7 or 8 years ago, where we were doing an egg retrieval for IVF. I mean, SART, to be clear, is really just managing and looking at statistics for success rates from on IVF success rates between one clinic to another, say, in a given geographic area. And it used to be, even not that long ago, that we were doing an egg retrieval and then we were just putting that embryo right back in the same cycle, hoping for the best. We would freeze the rest of the embryos, but everything was kind of lumped into this one cycle or 1 month of treatment. And it's changed so much over the last, 5 to 7 years, where the vast majority of our patients are now freezing, banking all of the embryos, and then transferring them, hopefully for the most part, one at a time, month after month. And that's really changed and made things a lot more complicated for SART to keep track of. But I think, if you look in a certain geographic area and you're really careful about comparing if you're making sure you're comparing apples to apples from one clinic to the next in the same age ranges, I think it does at least give you, some general idea of really not just the clinical protocols from the physician and clinical side of things, but lab success rates, because they are really different from one clinic to the next, maybe even just a few miles away. And so I think it's good to keep that information in mind. If you feel like it's confusing, I think, you have to do your best guess and, go see a clinic. And it's not like you have to stay with that clinic as well. Sometimes people will maybe go to one physician and get an idea and get their interpretation. And if you have concerns of any of the statistics you get from SART or CDC, maybe ask them what their interpretation is, because, sometimes it can be very complicated for, I think, patients to assess that information and get accurate information from the data given.
And I think asking a question is always a good thing.
Yeah.
Right? I think we always get embarrassed saying, oh, I can't ask this question because I'm going to look stupid. But actually, the reality is, by asking the question, you don't know what you don't know.
Right.
So by asking somebody that can explain it, you're going to be able to understand, okay, this is what that means. This is how this then pertains to my situation and how I can then progress.
Yes.
That's interesting. When you're choosing a fertility clinic, obviously it's a team effort, as we've just mentioned, right? From the minute you walk into the door through to the doctor. Can you explain a little bit about the embryology department and how that can be a differing situation from one clinic to another?
Absolutely. And it's not something that anybody as I think a patient coming in really thinks about, because they're not like the face that you see, right? They're all, it's kind of the crazy science behind the scenes that is hugely impactful to success rates from one clinic to the next. And a little bit of protocol. And I'd love to say, I mean, in general, we have good success rates, but I think at least half or more than half of success rates to any clinic and IVF success really is the lab. And it's not just like one big difference between one lab to the next, but it's all the little tiny, when you think about it, we do the clinical side, we, say do the procedure to retrieve eggs. They go through this like little Mr. Rogers window in our procedure room into the lab and literally little test tubes. And then that second that they go into the incubators in the lab, it's really important, I think, that the lab is, on a unified front. They have very specific protocols in place. They have good direction from the lab director, and all of those little tiny steps that happen from the second the eggs get to the incubator, fertilization protocols, blast development, which is when they're growing out the embryos for the 5 to 6 days in culture, all of those things, techniques, and that all the embryologists are well trained. I think they have to have really good oversight from the direction of the lab director. And I think it's surprisingly variable from one lab to the next. And it's hard to really, I think as a patient, really be able to synthesize or really understand that part of it. But it does have a huge impact on overall success rates with IVF in general. So it's important to think about that as well.
Because that is really a big part of the process that you would assume is standardized.
Yeah.
You would assume that the eggs are retrieved, they go into the incubator, step 1, step 2, step 3. But what you're saying is it's not.
No, there's differences in culture media, methodology for, when we do genetic testing on embryos, the methods that we use to kind of create the little hole and take out a few cells to do the testing on the embryos genetically. All those methods can be really variable from one clinic to the next and from one lab to the next. So I think all those little itty bitty differences from one clinic to the next can have a big impact on success rates with those embryos once and then we just get those embryos back and we're putting them with a little catheter into the uterus. Huge process that eggs, I mean, it's incredible when you think about the fact that, we've come in, the last like 50 years, barely so many changes with IVF success rates that eggs can come out of your body. We can grow an embryo that should be in your body that whole time, freeze it, do testing on it, and then put it back months or years later. And like that egg and embryo never knew it was even outside the body. I mean, it's incredible technology, but lots of changes. And it's a really cool specialty because I think overall success rates just continue to improve as we learn more as we go. And I think some labs are also a little more progressive in terms of, trying to always be on the forefront of changes that will hopefully implement improvements over the years. And so we've seen a lot of those changes, but I think not all clinics are really like trying to push the envelope, improve success rates as much as others as well.
So let's touch a little bit on the definition of success rate. You've said, and rightly so, that ultimately the dream is to have a baby. So that is the measure of success, walking home with the baby. Mm-hmm. But within the actual process itself, we have fertilization success rates, we have live birth rates, we have implementation success rate. So can you maybe walk a little bit step by step on those and explain those?
Sure. Yeah. I think the biggest things are, I think what they track from kind of the really nerdy embryology side of things is they'll look at, okay, from the number of eggs that we have retrieved. So that's like all eggs, get retrieved from each ovary, assuming that somebody has 2 ovaries and they come out of the body with a bunch of fluid. The embryologist looks at the eggs, figures out which ones are mature. Those are only the ones that are mature can be fertilized. And they may be either naturally fertilized overnight. And so they put the egg and sperm together and they just kind of party overnight and we check them the next day. And we can see the next day how many have successfully fertilized. Sometimes we do something called ICSI, which is where we inject one and like very intentionally inject one sperm into each egg. If there's male factor issues or any other concern about fertilization, sometimes we'll do that. And so they'll look at fertilization rates. So that's like, okay, maybe 20 eggs that were mature, but only 15 actually successfully fertilized. And we want to make sure, particularly in the case of ICSI, that the embryologists are having a good success rate with being able to actually put a sperm into an egg, which is surprisingly kind of manipulative, but they do great with that. And see how many actually fertilize. So they look at that. And then once they start growing those embryos out, for that 5 to 6 days, making sure that a good percent of those embryos are able to actually make it to what's called a blastocyst stage, where they have way more cells. And that's what we really want them to get to before we freeze those embryos to prepare for transferring in a separate month or a different cycle. And so in the lab, there's a lot of differences between, one lab to the next as far as what percent of those embryos can actually make it to that blast stage. That's another metric that we look at. We want to make sure we're meeting minimum standards. And surprisingly, a lot of embryos will drop off in that culturing process if they're not genetically normal or lower quality. So there's a lot of course, patient demographics that can affect that, but we want to make sure we're meeting minimum standards. That's something that kind of really intense lab statistics will look at, making sure that we're doing well there. And then more on the clinical side, eventually once that embryo goes back to a uterus, whether it's, the patient's uterus or to a gestational carrier, that we look at pregnancy rates. So it's just getting positive test result, and blood usually is what we're usually checking initially. And then further from there, we're looking at, ongoing pregnancy rates, which is usually seeing a gestational sac with a healthy baby growing. That's certain things that are really tiny still, but making sure that not only did they have a positive pregnancy test, but they've also gotten to the point where we call it graduation, where they get to usually 9 weeks and they're graduating back to the regular world of OBGYN at that point. And then lastly is, as you mentioned, really the ultimate goal is getting all the way through all those steps, creating the embryos in the lab, usually freezing them, transferring them back to a uterus with or without that genetic testing on them, and then getting to the goal of all the way through first trimester. But at the end of the day, really baby in your arms is what we call live birth rates. So that's all those steps, and then getting to the point where you have a healthy baby.
So it's really important to understand when people are talking about success rates, what are they talking about?
Correct.
Because it could be one versus the other, which could mean that you're thinking it's one and not the other.
Yeah, we watch a lot of those really carefully, because you could have a really high, pregnancy rate where, yes, they have a positive pregnancy test, but if a lot of those early pregnancies are resulting in early losses, which is what we call biochemical losses, where you have a positive test in the blood, but then it drops off and you don't end up having an ongoing pregnancy, then that's not really helping your cause, because at the end of the day, you want to have a baby in your arms. So you have to be kind of looking and interpreting those success rates that you look at SARD and other organizations really carefully, figure out the ultimate goal of having a baby.
So that's fantastic. Thank you so much.
You're welcome.